billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Nahmaduhu wa nusalli ala rasulihil kareem. Amma ba'd. Thank you very much once again for joining me for this session. We'll be talking about pediatric dermatology emergencies today. This is lecture 1 or presentation 1. And those of my colleagues who have joined us for the first time today, I'm Dr. Amjad, consultant pediatric dermatologist at Shifa International Hospitals Islamabad. And I've run the first pediatric dermatology purpose run service in north of Pakistan, predominantly in the capital. And for disclaimer purposes, this is a total pure academic CME activity. Myself, my CME department, and my organization and my hospital has no financial interests attached with this CME activity. Now, with regards to the presentation today, it will be slightly shorter because the next one will be slightly longer because of logistic issues today. And so we'll be talking about dermatological emergencies in perspective of pediatric dermatology and ER. So the topics covered today will be cellulitis, meningococcal septicemia, eczema herpeticum, and erythroderma. Before I start today, I would like to suggest to my colleagues, obviously all of us are physicians are scientists, but life in itself is bigger than medicine. So we should be looking outside the medicine for answers to everything rather than just sticking to the science and medicine. Because if you remember, Newton found the law of gravity because of apple. Obviously that was outside the medicine, and it was actually the life experiment or experience. So I want to, that's the way, or that's the ethos I follow in my teaching and my practice. So what I would share today will be something related to medicine, but in bigger perspective as well. So this is the disclaimer, and let's talk about Alexander the Great first. Only 1 or 2 slides, and then we'll obviously start our presentation today. So those of us who read history, Alexander was son of King Philip II, and King Philip was offered a fantastic stallion, but he declined because the horse was so strong, powerful, that he thought that the horse could not be tamed. But Alexander liked it, so he took that stallion on board and gave him the name Bucephalus, or Oxhead, and that served him very well until one of the last wars he fought. And on his the way back from the Battle of Hydaspes, while passing through the current Pakistan near Jhelum, actually his horse died. His horse was very much, he was in love with that horse. So that's the reason he created a monument for it. Unfortunately, over time, that monument was eroded with the time and the situation around that area. And it's still here, Alexander Monument. You can see it's Jalalpur Sharif near Jhelum or Mandi Bahauddin. And so Dr. Abdul Qadir Khan, our nuclear scientist, in 1997, due to his history interest in history, he recreated what it was initially built as. So those of us who want, who likes travel and a little bit of history, I will encourage you guys to, on the way to Kyoda salt mines, one of the biggest, and not the biggest, but I think it's the second biggest in the world. Correct me obviously if I'm wrong. This comes on the way. And there is a reason I'm sharing it. I will share it at the end. It's related to medicine in one aspect. So let's talk about our topics today. It's cellulitis. And you can see cellulitis is a very common. I'm sure all of us have, the frontline staff have come across cellulitis in their practice one way or other. And it's the infection of the lower dermis, subcutaneous tissue. Sometimes it's solitary or localized, but mostly once cellulitis starts and it sits in, it starts to spread. It's painful, erythematous, active margin. So, and obviously it moves, the active margin moves. And that's the reason, I will show you a photograph. Whenever we see cellulitis, the suggestion is to mark it with a pen or a marker, but it should be permanent, not the one where you can easily clean it, so that you can even inadvertently, if somebody wants to rub it off, it hangs around. So every so often, 12 hours, 24 hours, as the shift changes, handovers happens, new medical staff comes in, they can monitor and observe, and even we ourselves can monitor next day whether it's getting better or getting worse. So you can see it's very well marginalized, outline is very clear. And so this is cellulitis. Let's talk about the dermatological manifestation. It's erythema. It's obviously painful if you ask the patient. There is sometimes associated wheals or hives or sort of urticated lesions. If it's over the joint, it's sometimes difficult to move the joint as well. So, and there is subcutaneous edema. There is sort of, sometimes it can be oozy if there is a scratch or there is open skin or fissuring. So what are the causes? So one, obviously, trauma that can introduce the infection. Second, immune deficiency. Quite a few other things. As the age crosses, let's talk about in general. If it's grown-up patients or adult patients, then venous stasis, lymphedema, leg ulceration, diabetes. In young children, we have to rule out diabetes. Immune suppression, we have to look at if they are on any steroids. I've seen a nephrotic child who was on steroids and had cellulitis. Chronic diseases, so kidney, renal diseases, liver diseases, and obviously pregnancy and alcoholism is something when it's for grown-ups. So the most common bacteria that causes cellulitis is Streptococcus pyogenes, 2/3, and roughly Staph aureus is the 1/3. That's obviously a rough distribution. Uncommon germs are there as well. It's mostly, almost always unilateral. If it's bilateral, think outside the box before labeling it as a cellulitis. And while it heals, because there is so much inflammation in the skin, there is so much activity in the skin that the top layer of the skin can sometimes peel off and can be flaky. So don't be worried, don't be sort of hesitant to sort of mark it as a sequelae of cellulitis when you're following up a patient with cellulitis. Obviously, if it is around the orbit or specific areas on the face, it is a dermatological emergency because it can cause infection, different type of, it can spread through the venous system on the face. It can go into the brain tissue or cerebral vasculature, and then obviously that's another issue. It can affect locally in the eye, pressure symptoms. So that's one thing. It can affect the intraocular organs or sort of subcutaneous tissue. And so there are so many things. Vision is very it can cause blur vision, it can cause intraocular infection. So these are the few things which we have to worry about if it's around the eyes, but obviously everywhere it's the same. So with the sort of clinical appearance, you can see powdery orange or sort of dimpled skin. It's slightly warmer. It can blister. So I said fissuring, urticaria before, but it can blister, erosion, ulceration we've discussed, and then obviously ecchymosis and hemorrhagic bullying. Why it's an emergency? So necrotizing fasciitis, gas gangrene. These are obviously the severe end of the spectrum we're talking about, but that there is a strong potential. Remember, if it's an immune suppressed patient, steroids, chronic disease, kidney, liver disease, then obviously these are more of a sort of outcome scenarios. In immune competent person, if we go in quick, it will be better and we will be able to control the infection sooner. Now, sepsis. Sepsis. That's the problem with all these dermatological emergencies or any infection. We have to be worried about sepsis. Infection of other organs, slightly less common, pneumonia, but it can happen. Endocarditis, so that's another thing to consider. Investigations, obviously, clinical scenarios, clinical features, as like other infections, increased white cell count, CRP, blood culture, if positive, sometimes blood culture. Again, the blood culture depends on the way we take it. Have we taken enough sample? And the logistics of sending it to the lab. So, all these things do count. Imaging, if it's a limb, if it is extensive, and if there are involved underlying joint symptoms. Doppler ultrasound for blood clots, it's for deep venous thrombosis, again on the limbs. And MRI, especially in the case of necrotizing fasciitis. Differential diagnosis, obviously, eczema looks around that. Any dermatitis, any skin inflammation will look like it. But again, if you're worried, if there are symptoms, systemic signs, spreading, then think outside the box. Again, eczema is usually bilateral. Dermatitis is usually bilateral. Unilateral, we are worried about infection. Drug eruption, it's a fixed drug eruption you're talking about, and it's usually unilateral as well. We have covered it in one of the previous lectures. Psoriasis and thrombophlebitis. Most of these are very clear when we take the history and do the examination. Now let's talk about a bit of treatment. So it's rest and elevate the affected limb. Again, the edge of the involved area of swelling should be marked to monitor the progression. Analgesia, fluid intake, and management of coexisting skin conditions like venous eczema or tinea, or whatever we think is the underlying pathology there. General treatment, it's now again slightly unfortunate we don't have flucloxacillin in Pakistan, to my knowledge. Please correct me, obviously, if I'm wrong. But we do have coamoxiclav, which is amoxicillin and clavulanic acid. We do have penicillin G, and cephalosporins as well. So ceftriaxone, cefotaxime, or these are the options we have. Clindamycin, Septran, which is the combination of trimethoprim and then doxycycline, vancomycin. These are other things which we can use. Another broad spectrum. Now, unfortunately, here, those of us who are practicing in Pakistan, I've seen quite a few patients, at least 4 or 5 pediatric patients, given linezolid by general practitioners. So I will encourage you, don't just jump up to the broad spectrum antibiotics just because you can. Go systematically actually, and be logical. Start with common antibiotics, and then discuss with microbiology colleagues, infectious disease colleagues, or if you think you need to refer them, please do refer them to the hospital departments for further investigation or treatment, if possible. My practice is, if I'm out of my depth, I usually will ask my other colleagues. There is no shame in asking, because we are all, at the end of the day, are humans, and our knowledge is limited. Let's talk about meningitis. Meningitis and eczema herpeticum will take a bit longer in this presentation because they're very important. Those of us practicing pediatrics, we have seen meningitis quite a few times because it is reasonably common. You can see I've taken these slides from Meningitis UK, Meningitis Foundation USA, and then some of my slides. Because it's very important. So it's always better to collaborate, use the information available, and give the idea holistically. So we know the meningococcal disease is because of Neisseria, and then it's an aerob, gram-negative, and again, it's just going back to our pathology and microbiology. But there are 2 types. One obviously causes gonorrhea, the other one causes meningitis. And so what is meningitis? So it's inflammation of the protective layers or meninges that surrounds our CNS, which is brain and spinal cord. And septicemia, so meningococcal septicemia we're talking about, which is obviously a dermatological emergency. So what is septicemia? It's when the infection spills into the blood. In layman terminology, we say it's blood poisoning. And it's obviously septicemia is a cause of sepsis, which can be a life-threatening condition. Meningococcal disease, it was first described in 1805 by a physician in Geneva, Switzerland. Nowadays, it's the UN head office. And Neisseria was identified in 1887. And so meningococcal disease, it's meningitis and septicemia. It's a combination of both. And as per the UK's Meningitis UK data or sort of guidance, it's the most common cause of bacterial meningitis is meningococcal disease in UK. There are 5 strains, but luckily there have been vaccinations around, so we are covered mostly from most aspects of the disease. That's the reason we encourage vaccination in our general population. Glass test, tumbler test, always advisable. Laymen can do it at the, even telephone, WhatsApp, whatever consultation you do, you can ask them to do this, and that will, at least that way you will be screening them whether if there is anything nasty hiding there. And so the rash do not fade under pressure. So this is glass test. And so fever, rash that do not fade under pressure is a medical emergency until proven otherwise. So the combination of two. Don't wait for the child to be systemically unwell, because meningococcal disease, unfortunately, is lethal and it spreads very quickly. I remember I was first year intern in Swindon, I think it was, and Great Western Hospital, and unfortunately, within 3-4 hours, the 9 people had admitted someone within 3-4 hours. By the time we were managing the child, or the night team, by the time we were taking the handover, the child was already in sepsis, and we had to involve the intensive care, and it became quite difficult to treat the child. So I remember that from my training days. So it took only 1.5 hours, I think it was 90 minutes, before the child was severely sick, before coming into the hospital and then being sick. So I take it personally very seriously. I will advise you strongly, if you are worried, jump in. It's always better to be safe rather than sorry. So do not wait for the rash. If someone is ill and getting worse, get medical help. And again, bearing in mind dark skin, in Pakistan, we have a whole variety of skin from Fitzpatrick type 1 to type 6. So do think outside the box. The rash might not be evident that much to the family. So the impact of meningitis and septicemia, 10% of bacterial meningitis, still very sad to know, but still in this age and era of science and available resources, 10% will die. It's estimated up to 1% in every 2 or 3 who survives will have some sort of permanent issues. We'll talk about the issues as well. And after effects are very common. What are the after effects? Why we need to know about these? So that once we know, we'll take this disease seriously, we'll jump in early, we'll treat it early, we'll talk about the treatment as well. But God forbid if somebody has it, and then we can at least update the family. We can encourage them to learn about these things. So hearing loss, that's the reason we can do the hearing test once the child is recovered from meningitis, sight problems, speech problems, organ damage, skin scarring. Neurological, you can think about anything, epilepsy, headaches, memory, concentration issues, emotional difficulties. And so meningitis can devastate lives within hours. That's what I told you earlier as well. I shared my personal experience, and its impact can last a lifetime. This is obviously one of the slides where you can see I will show you the better one a bit later. Epidemiology, humans are the only hosts. Person-to-person transmission is in crowded conditions. So again, we have COVID-19, which has trained whole of the mankind how to reduce person-to-person transmission, mask, hand hygiene, social distancing, so many things we have learned over the last 2 years. So we have to make it part of our life. Infectious diseases are lethal. They can be lethal, and they can be life-changing. Look at COVID. It has changed the whole life of the humanity on planet Earth in the last 2 years. So highest incidence for meningitis is under 5, and particularly under 1. They have passive maternal antibodies, but that declines by the end of the last year, and then their immune system is quite immature to handle that. Now you can see this is quite widespread, extensive, last sort of end stage of the skin, where the petechiae have coalesced into hemorrhagic bully. Once it reaches to this stage, the child or the person will be severely sick. So please do take it very seriously. Meningitis is a very damaging disease. Immunogenicity, so protective humoral immunity develops against the same or closely related organisms. So colonization in the nasopharynx, this is obviously over the time we have learned from our scientific colleagues. that for the same serogroup, we will develop some humoral immunity, but not against others. And then cross-reactivity or cross-reactive protection again occurs if somebody has E. coli, K1. So there is some protection available if we have either colonization or are infected with other sort of antigenic strains of other germs. Now, clinical presentation, more than 2 years and newborns and infants. So again, more than 2 years, the typical high-grade fever, headache, neck stiffness. So, neck stiffness, neck rigidity, neck stiffness. Please always think about it: systemically unwell, rash or no rash, headache, and neck stiffness. And then obviously other signs like vomiting, discomfort, confusion, sleepiness. So all the organ systems, especially brain. Newborns and infants, they have less chances of developing neck stiffness. So please do. That's another reason that we have to emphasize. We have to think outside the box for them. And if the fontanelle is open, they can bulge, and they can appear irritable, slow, and inactive. Vomiting is another sign in young children. So now this is the same slide, but in a slightly detailed from the National Foundation for Infectious Diseases. You can see white blood cells, meningococcal, and then obviously this is the Gram stain. Laboratory large cell number of cells encapsulated in CSF. So obviously LP, full septic screen, and then our fantastic colleagues from the labs will help us diagnose the condition, what type of germ is there. Now, treatment. Penicillin is the drug of choice. So again, remember, penicillin is the drug of choice, not anything else. Unfortunately, here in Pakistan, I've seen my colleagues, they might be very well versed with the antibiotics and they use very strong antibiotics, but I usually leave it for the infectious disease or microbiology colleagues to advise on the stronger, more sort of newer versions of the antibiotics. I still personally use penicillin and then obviously step it up accordingly as indicated. We do obviously have to offer chemoprophylaxis to the close contacts. So rifampicin or sulfadizine. I personally have used rifampicin in mostly in the patients I've seen and their sort of family close contacts. Again, non-blanching rash. This is mild, but it was still non-blanching. This was quite early on. This is not early on. You can see it has petechia have coalesced, and unfortunately there is a lot of damage. And even looking at this photograph, I'm sure all of us will think that the child is systemically unwell. Incubation period is usually roughly a week. As a sort of general rule of thumb, it's a week. Infectious period is as long as the germ or the meningococcal germs are present in the nose and oral secretions, or until 24 hours after initiation of the effective antibiotic treatment. So again, most of the families will ask, if we start the treatment, when is our child okay? When he is less infectious or non-infectious. So it's usually 24 hours. Again, rule of thumb, some people will say 24, some people will say 48. Scientifically, it's 24 hours. Epidemiology, person-to-person droplet respiratory or throat secretions, close contacts but prolonged contact. Living in the same quarters for military or boarding schools. So think outside the box, or sharing the eating utensils, drinking utensils, things like that. This is the treatment. So you can see administration of this is chemoprophylaxis. I've used personally rifampicin. Very rarely I've used ceftriaxone. And once or twice I've used ciprofloxacin, but this is obviously the general advice, again from the National Foundation for Infectious Diseases. And disease burden, again from the UK, you can see 1 in 10 people who contract meningitis will have issues with septicemia and unfortunately will die. So 10%. Think this is 21st century and still this is this disease is high mortality. And 25% will have life-altering permanent effects. What kind of effect? You can see this, and you can see this actually. Limbs. Very important for young people. Everything is important in our life. Amputation happens, I've seen personally. And kidney damage, lung damage, arthritis. So please take it seriously. Who gets it? Usually immunocompromised young people or sort of people in close contact can spread it as well. So meningitis and septicemia in short can severely disable, can kill in hours, and can affect anyone at any age. So please do consider it in your differentials almost always. Just as one slide giving you all the reasons or all the ideas behind it, and you can see bacteria is one of them, but other things can happen as well. And this is the website if you want to read more about general ideas, demographics. This is obviously a British website. Now let's talk about eczema herpeticum. So I wrote this article in 2015 with my supervisor, Dr. Lindsay Shaw, fantastic pediatric dermatologist from Bristol and Great Ormond Street, London. This was for Archives of Disease in Childhood, RCPCH, Royal College of Pediatrics and Child Health Journal, 15-minute. And luckily, it got the cross mark, which is the editor's choice for that season or that publication. Now, 15-minute consultation. So eczema herpeticum in a child. It's one of the 12 dermatological emergencies, not pediatric, but dermatological emergencies. So that's the reason we have roughly a dozen dermatological emergencies. Pediatrics are slightly different, while adults are slightly more. What is eczema herpeticum? We have talked about eczema in the past in one of the lectures, but we'll talk about only eczema herpeticum. You can, I'm sure you will remember from the previous lecture that eczema is an abnormal barrier function of the skin. You can see the slide here and the diagnostic criteria as well. And again, with that, the poor barrier function will result in infection if there is any germ that comes across the skin. Now, this is the general morphology for eczema: erythema, edema, vesicles, and eczematous pitting. But if you look on the right side of the screen, the first two photographs in vertical line, they are present. They show excoriation, mild secondary infection, slightly impetiginized on the lower photograph. But if you see the last line, vertical line of the slide, where the two photographs are, all the lesions are monomorphic. So they are punched out monomorphic multiple lesions. Monomorphic means all look the same. If you look closely, all look nearly the same. This is eczema herpeticum. And that's what we have to worry about. Key aims of the treatment: improvement and maintenance of basic skin care, diagnosis and treatment of secondary infection. Almost always, we'll talk about it, but almost always eczema herpeticum has secondary infection. So that's the reason you have to treat two together. Until unless you are sure there is only viral, just treat the viral. So abnormal skin barrier function predisposes to the infection in eczema. Early recognition is vital. In 1887, it was first reported as KVE. But again, the name is eczema herpeticum now, but we use in literature and in common practice. Now, common questions which families will ask you: what is the Staphylococcus colonization rate of eczema patients? Think about it. I'll give you the answers. How common is HSV infection in under 15? What is the mortality rate of untreated eczema herpeticum? That's the reason it's an emergency. And result of delay in starting antivirals. What is the result? So 90%, that's the reason I said almost always there is secondary infection. How common HSV infection is? You can see roughly 1 in 15. What is the mortality rate? Around the same, 6 to 10%. So if you remember, meningococcal disease, 10% mortality. Eczema herpeticum, roughly 10%, 6 to 10%. And result of delay in starting antivirals: increased hospital stay, other chances of getting exposed to the germs, other complications. So many things can happen. Spectrum of disease, you can see localized herpes simplex viral infection. So it's a localized one. This child had no systemic signs. This one obviously is monomorphic rash of eczema herpeticum, punched out lesions. With secondary infection, you can see honeycomb crusting on the top and lower end of the photograph. Differential diagnosis, I will show you the photographs. Chickenpox, chronic bullous disease of childhood, We can easily get confused with these things. Contact dermatitis, but history will tell us. History, examination, and then sort of making our differentials. And impetigo. So how do we screen it? Viral swabs, viral cultures, PCR, and direct fluorescent antibody stain, whatever is available locally. Now, usually we will encourage, where available, to use PU score or pediatric early warning score, and that way you can judge whether the patient is well, not well, or needs immediate attention. Key warning signs of eczema herpeticum: in the presence of monomorphic blisters, rapidly worsening painful eczema, clustered blisters consistent with early stage cold sores, punched out erosions, systemic signs, fever, lethargy, or distress. Complications, why we worry about it? One, obviously 10% mortality roughly, but the other things are complications. Delayed healing. You can see the young girl, eye involvement. So keratoconjunctivitis, possibly stromal scarring and blindness. So that's the reason. If it's around eyes, this is one of the reasons to see an ophthalmologist immediately. 6 hours, some people will say 6, some people will say 12, but immediately on the same day you have to see the ophthalmologist to rule out keratoconjunctivitis, and if need to be, then needs to be treated concomitantly for that as well. Secondary bacterial infection, you can see the lower photograph, scarring and post-inflammatory hyper or hypopigmentation, and then sepsis, viremia, other system, multi-system or multi-organ involvement. Treatment. So systemic treatment is acyclovir. Again, this is BNFC from that time when I published this. So it's age dependent. Again, I will strongly encourage my colleagues here, my junior colleagues, my senior colleagues, those who don't practice this. Most of us do anyway, but those of us who don't, please do consider using BNFC or any other formulary available, and advise dose according to the age. Pediatric dosing is different than adult dosing. If you're not trained in pediatric formulary or prescribing, please do get yourself familiarized if you see pediatric patients, because doses are different. And you can see here we can use valcyclovir, foscarnet if need to be. Again, for foscarnet, I will speak to my infectious disease or immunology or microbiology colleagues. Let's do a little bit of quiz about eczema herpeticum. Now, let's test our own knowledge. In eczema, secondary infection should be considered. If found, you can select as many options as you think are appropriate. Crusting, weeping, erythema, multiple excoriation. Now, eczema herpeticum, the number 2, has erosions, blisters, vesicular rash, or papules. And number 3, for widespread eczema herpeticum in an unwell child. One option is an outpatient with oral medication. Now, this is an unwell child and widespread eczema herpeticum. 2 points we have already given here. Outpatient with oral medications, inpatient with intravenous antiviral medications, and inpatient with oral antiviral medications. And you can see the answers here. For the first one, all are relevant. For the second one, D is not relevant. And for the third one, inpatient with intravenous antiviral medication, because it's an unwell child with widespread eczema herpeticum. Key messages for eczema herpeticum: early diagnosis and systemic antiviral therapy can minimize the morbidity and mortality. Periorbital lesions warrants immediate ophthalmology referrals, and eczema herpeticum can potentially cause blindness and even mortality. Hence, prompt diagnosis and treatment is essential. You can see here, eczema herpeticum. This child came an outpatient with perioral involvement as well. This child needs inpatient admission because it had fever, was generally unwell, lethargic. Second, needs ophthalmology, and obviously IV. This is the references for up until now, but let's talk about now. Yes, for eczema herpeticum, that I will encourage you, especially my junior colleagues, if you want to keep yourself updated, there are appraisal or yearly CPD, CME opportunities. In America, it costs $39, but in UK, it's free with NHS login. So if you know Most of us would have worked in NHS, so we'll have our NHS Athens login. If it is valid, please do access that. It's for education purposes, or this is free for all, regardless. This is Imperial College London. They have done this, health professionals, allergy videos, eczema, infection. So many things are there. Fantastic resource. itchysneezyweezy.com. Please do review that and encourage your juniors to learn from this fantastic educational resource. Let's talk about the last topic, erythroderma. Erythroderma is the term used to describe intense and widespread reddening of the skin due to inflammatory skin condition. It's also known as exfoliative dermatitis, extensive exfoliative dermatitis. It's rare, but it can arise in any age. You can see all the skin. Well, most of the skin is red, inflamed, scaling, painful. And the person is very miserable. And again, why it's an emergency? Because it can result in morbidity and mortality. Unfortunately, I've seen one patient recently in my outreach clinic in Peshawar, walked in, was literally, we say 90%, it was, I couldn't see any normal skin, erythrodermic. I had to, because obviously it was my outreach clinic, I had to sort of send the patient to one of my colleagues who is a professor locally, who very kindly looked after that child. But you know, a 15-year-old who was suffering like that, according to the family, from last 8 months, been to different community doctors, you know, outside, and everyone was treating with topical or oral. So, you know, I will encourage you to get yourself used to these emergencies, so that as soon as you pick it up, we can help our patients. Now, erythroderma can be because of any underlying skin condition. So it can be because of atopic eczema, psoriasis, anything. But erythroderma is a term used for more than 90% skin involvement. Drug eruption can be a cause as well. Pityriasis rubra pilaris. Think about it as well, because it is reasonably common here. So by definition, more than 90% of the skin affected, it's warm to touch, it's itchy, it's painful. Eyelid swelling can happen. That patient had eyelid swelling when he woke up in the morning, and as the day passes, it would come down. Scaling, as I've mentioned, and lymph nodes, nails. So if it's long standing, it will affect the nails. Palms and soles can have keratoderma. So many things. If it affects the hairs, it can reduce hair density, sometimes baldness. Complications. This first and foremost is heat loss due to hypothermia, fluid loss. So think about these two, heat loss and fluid loss. And then secondary infection, because the skin as an organ will have no protective barrier function left. Generally unwell can lead to pneumonia, hypoalbuminemia, and then obviously long-standing erythroderma can result in pigment change. Diagnosis, you know, blood counts, eosinophilia, but again, marked eosinophilia, we should be thinking outside the box. So blood film should be advisable. And C-reactive protein, skin biopsy will give us diagnosis. Direct immunofluorescence will benefit if there is blistering, so autoimmune blistering disease, and connective tissue disease, if we are considering that as the underlying cause. Remember, erythroderma is a presentation. There is an underlying disease which is causing it. So we have to find that disease, so that once we start treating that, we'll get erythroderma better as well. It's potentially serious, even life-threatening. General measures: discontinue all unnecessary medications, monitor fluid balance, body temperature, skin moisture, wet wraps, mild topical steroids. Remember, it's the whole skin, so don't give them very much. You know, just don't overload them with the steroids. Antibiotics, antihistamines, and then obviously treat the underlying condition. If it is atopic eczema, then you know, systemic steroids for that. Acitretin or methotrexate for psoriasis. So, you know, think about the underlying condition. We have to treat both erythroderma and the underlying condition. Now, with that, our presentation for today is at the end. We'll have other topics for next time, which is the pediatric dermatology emergencies in ER. That will be slightly longer, which is tomorrow. It was supposed to be next week, but next week is Eid al-Azha. So for that reason, we are doing it tomorrow, but bringing it forward. So apologies for that. If you have some things scheduled for tomorrow, if you can attend, that will be fantastic. Otherwise, it will be available as a video link on Shifa International Hospitals website, like the YouTube channel, CME, or Facebook Shifa International CME's page, my website drmjathan.com, or my Facebook page as well. Now let's talk about why I discussed Alexander the Great initially in this lecture, because Alexander's body didn't begin to decompose for several days after his death. So that's written in the history, that his body, although it lay without special care in places that were moist and stifling, showed no signs of such a destructive influence, but remained pure and fresh. Remember, this was the most fearsome, the biggest warrior of all time, and his body was not decomposing. Why? Well, there is a reason for it. We think he had at the end of his life Guillain-Barré syndrome. So he was alive, unfortunately, for the few days before his death. And because of paralysis, he died ultimately. So it was a painful death for him, which is very sad to hear. But history teaches us a lot of things. With that, thank you very much and see you tomorrow. And inshallah, we'll be finishing our 6th lecture series tomorrow with our last lecture for pediatric dermatology emergencies in ER. Thank you very much.